It's Off Exit 10, presented by Capital District Sport and Fitness.
Then when Mike proposed it, I was like, yeah, dude.
When I have an idea, just
And I needed something.
you just
Run
go.
with it.
Yeah, these guys they're trying to get me to calm down.
I mean, not really.
Maybe not calm down is like the best way to put it.
No, because
More focus, maybe.
No, less on edge
Mm,
is
less stressed.
chill out.
yeah.
Like, you know, we got your back, you got our back. We're a team, and that's what we're here for. So, you know, that's why you built the team you did. You know.
Like you just have too many ideas.
No, I feel like I pre-filter my ideas in my head before I present them to people. So I feel like I'm not running to the guys in here with all these ideas and being overwhelming.
Yeah.
I fixate on things
Okay.
unnecessarily. And so-
Sometimes it's necessary, but like sometimes it is necessary,
Right.
Because like that's part of the reason why we've gotten to where we are.
That's how you
is
get
like
stuff done.
there's a balance to it, and that's just something that like even like the best business owners and stuff like that, they do have hyperfixation on things. That's why they're successful. But then it's figuring out how to balance that.
Well, yeah,
Right.
Jordy's had this talk with me where he's like, you should go on an SSRI and just like to dull those fixations. And I'm always afraid, but she tells me it's not true, is that it's going to dull my like that little bit in me that just is like, go, get this done,
Yeah.
go.
That almost the ambition
Sure.
side of it.
Yeah, people tend to think they're like anxiety is like a superpower.
Yeah.
It's just like, no, it's just getting in the way. You may think that, but it's just in the way.
Fine
Figure it out.
balance. Yeah. As long as you have people to keep you in check, I think that's good.
Yeah, I'm thankful for all these guys and Jordy, even though if it's a pain for them sometimes.
That's why we wouldn't be here if we didn't want to be. So
That's true.
Thanks, guys. I appreciate it. But no, Lisa, I appreciate you for doing this.
Of course.
How'd we connect? You emailed me?
Yeah. I was just looking for local business owners, people in the health space, gym owners, whatever, to connect with and try to get the word out about my new business. So I think I just emailed you and asked if I could come and meet you, and you were very nice. Usually what I like to do is offer like a free workshop for people who, you know, if you have a gym, offer it for free to your current clients, just to provide education and help, you know, spread the word about what I can offer and to allow people to meet me and get to know me face to face before they decide if they want to, you know, utilize what I'm offering. But you mentioned the podcast, and I've never been on a podcast, so here we are.
First one, I love it. Yeah, we've like done a few workshops before, and I always feel like us and whoever the person is putting on puts in so much. I don't know if you feel this way. Puts in so much effort, and it's thoughtful and great, and then the attendance is never what I want it to be, and I feel really bad for the person coming in who put in all this work.
Yeah.
And I'm like, oh, there's 6 people here, and it's just so great, and you put in so much effort.
Right.
And I'm like, oh, I just don't know if this is the
Yeah.
best mode.
I appreciate you, you know, seeing that and taking note of that.
Yeah.
yeah, because we've done it in the past with people, and even somebody we've had on the podcast
Yeah, it's
after
correct,
the
Paul.
fact.
Yeah.
And we thought it would, and it, you know, we had a decent turnout, but not what we thought with the work that we, you know, he put in and we put into.
Totally.
Put it
I
on.
feel like, Paul, the pods always led to better referrals.
Yeah.
Yeah.
Somebody listens, and you get this hour and change where we're talking, and they're going to know who you are
Yeah.
and know what you do, and go, oh, yeah, I think she can
Totally.
help me.
And it also allows us to know who to recommend you to,
Yeah.
right? Like that way, it's not this guess and check.
Right.
It's more of like, oh, okay, this person's probably a good fit, and you know what? If it's not, you know, we tried, and
Yeah.
that's what it is.
Right.
For
but
sure.
like, and you know, there could be a multitude of things of why it's not a good fit, but like in the same breath, like more times than not, it's going to be a success because we've gotten to know you over this hour and a half we'll be on here, and then that will allow us to be able to translate over to our clients too.
Absolutely.
Jay, I've never had the one with the back on the chair. This is
Ooh.
great.
You want to keep that?
Yeah, do you have the non-back?
Yeah.
Lisa, you have a back?
I do have a back.
Yeah. No, I've never had the back.
You got
I
new
can't believe
chairs?
we've never done that.
Whoa, I feel good right now. Yeah.
Mike, you know, we're getting up there in age, Jordan. So yeah, we're a little
Yeah.
older than
We
you.
need the
Okay.
lumbar
Yeah,
support.
you guys enjoy that.
Was this an accident?
It was an accident. Yeah. I'm glad it's working.
Okay, Lisa, but yeah, let's get into, because we've had a couple other NPs on in the past who act as primary care physicians, and who are outside of like the kind of corporate medical system, the kind of concierge, if that's the right term. Which is why I was so intrigued when you reach out, because you have that aspect, right? So the Mama Coach and the women's health stuff you do, that is right now on the side from your regular job.
Correct. It's my side hustle.
What is your regular full-time position now? And then we'll get into...
Sure. So I'm a women's health nurse practitioner.
Okay.
So that means I have a master's degree in nursing. Some NPs have doctorates, but the minimum is a master's degree. So I work at a rural hospital system out west, and I do full scope GYN care, all outpatient. So it's in an ambulatory clinic. It's not actually in the hospital, but we're part of a larger hospital system. So I see women and girls, from onset of their first menstrual cycle through being well past menopause, full scope, whatever that entails in terms of, both preventative and a bit more complex chronic women's health issues.
What are the most common chronic women's health issues that you see?
Menopause is definitely up there. I'd say just off the top of my head, maybe like 45% of my patients are struggling either with being in perimenopause or are postmenopausal and struggling with issues stemming from that. PCOS is another big one. That stands for polycystic ovary syndrome. That's kind of a misnomer, and I think we're finally starting to get more research into that whole disease and what it means in an individual person. It can look and present very differently in individuals, but that is a really big factor that leads to issues with fertility, irregular menstruation, higher risk for diabetes and insulin resistance. It's like a whole body thing, and it's very still poorly understood, I would say, by most providers and patients. Endometriosis is another one. That one's getting a lot of attention right now on like social media, finally, because that's also been very understudied, and a lot of providers don't really know what to do with it.
Is that why these, like a PCOS or an endometriosis, take so long to get diagnosed? Just because they are understudied, so practitioners just don't even know?
Yes. I'd say that's one of the most common reasons. You do run, you come across providers who just are burnout and just don't care,
right.
Or have the bandwidth to do the additional research that it takes to, being in medicine, everything is constantly changing. You have to take initiative and keep up to date with the new research and the new guidelines, and a lot of people just don't do that. But when I was in school, I graduated 2020. We barely learned about endometriosis. You really have to, take the initiative and take the extra time into your day to look up the new studies and figure out who to refer to, how, depending on their fertility goals, their main issues, what to do with them. It's a case-by-case basis, but the education is really lacking.
Was your schooling specifically in women's health, or was...
Yeah. So when you become a nurse practitioner, you can either be like a family NP, which is kind of the broad spectrum. You can really get how niche you want to, or just do primary care. But I specialized in women's health. So I did do, you get your foundational courses that you can apply in primary care, but then a lot of more specialized stuff into women's health specifically.
And you did your schooling where?
Yale.
At Yale. You're not from the Northeast, though, right?
No, I'm from the South, North Carolina.
So school is what brought you up here?
Yes. I've kind of moved all over. I'm from North Carolina, went to school in undergrad in North Carolina, and then was planning to stay there. I had a research job at UNC, which is where I went to undergrad. And then I just decided I don't want to do this. So I just moved to California on a whim, and I figured it out from there, and then applied to nursing schools. I did not get into UCSF, which is where I really wanted to go. So I went to Yale, which obviously is a great school, great program. And that brought me to the Northeast. And then I went back to California for a little bit and then decided I missed the Northeast. So here I am.
Here we are.
Yeah.
How does your role differ from like an OBGYN at your primary place of employment?
That's pretty much what I
That's what it
do.
is,
Yeah.
yeah.
I don't do much OB, so like prenatal care.
Right.
My passion is GYN, the GYN side of things. And that does include fertility, preparing for pregnancy and preconception. But I don't usually see patients like throughout their pregnancy. Right. I don't deliver babies. Yeah.
What made you then want to start your side thing right now? Did you feel like you just weren't able to help women in the way you want to?
Yeah, kind of. So what's tricky that you'll hear a lot of people in medicine, healthcare talk about is how tricky the insurance model makes, how much that impacts how you are supposed to practice at work. You'll hear a lot of people saying that they're packing their schedules. Administration is really cutting short the length of time you have with each patient. And then they're also pushing how to bill your visits. And they want you to be maximizing the amount of money you get reimbursed by insurance for each appointment. So that means taking less time with each patient because they want you to maximize how many patients you're seeing. And then that means, doing all this other stuff that insurance will pay you back for, whereas like lifestyle education, that doesn't really get you much money.
Right.
But that's what we are missing in healthcare. So I really enjoy educating people. I love like empowering women to understand their bodies because in school, you don't learn anything. You just learn like use condoms, and that's pretty much it.
Right.
So a lot of women in their 40s, 50s, 60s, 70s like don't understand what their hormones do or were doing and how that's now impacting their health. Pretty basic stuff. People just don't know, and that takes a lot of time to educate. And then, not just how your body works, but how your lifestyle impacts your health. There's all these different nuances. And just like hearing, that's another piece is like what I've heard and learned from my patients who have taken an interest in changing their lifestyle to change their health and seeing what that's done for them. I then absorb that, and it inspires me to go research, how diet can affect your risk for thyroid disease.
Right.
And then I can use that and bring it forward back into my patients. So it's kind of like what I do at the Mama Coach is kind of a mixture of like nursing care. I can order labs, imaging, I can prescribe, but it's also health coaching. And it's very personalized. So I spend a lot of time with them at their first appointment. We do a deep dive into their health history, what they're struggling with, and then we decide together, like, what are your goals for the next 6 weeks? And how can we make that happen?
And a lot of those clients are dealing with infertility issues, perimenopause, menopause.
Yeah. So my practice through the Mama Coach right now is pretty specialized for fertility, infertility, and then, perimenopause and postmenopause.
I think that's so important, though, because what also draws me into this kind of subject matter is my wife has endometriosis, so I've just watched her go through it for years. Painful periods, doctors brushing that off.
Yeah.
Oh, that's normal.
Yeah.
Oh, your labs look okay. Just like, sorry, this is where you're at. And then that causing infertility issues.
Yeah.
So I've seen just how, and I'm lucky she works in the healthcare field too, so she's been so proactive over the years.
Yeah.
But gosh, what if you are somebody who isn't proactive, whether like speaking with authority figures, like doctors, questioning things, being willing to do your own research, being willing to go out of like the regular systems.
Yeah.
Puts you in a tough spot.
It does. And that drives me crazy when I see people who, say I've told 8 different doctors about this symptom and they've all brushed me off or just like handed me the birth control pill and then sent me on my way. And that's just like, drives me insane.
And my mom worked in the healthcare field. She worked in different aspects of it. But like one of the things that she always talks about is like, if she has questions and like the doctor's trying to like tell her like, all right, trying to like almost like get her out. She's like, wait, nope, I'm not done yet.
Yeah.
I have a few questions.
Yeah.
Actually. And she like will not like let them end the appointment until her questions are answered. And it's funny because I tell her, I'm like, most people won't do that.
It's true.
Like male or female. Like I wouldn't necessarily have like the balls to do that. Like my mom was just like, yep, hold on.
It's really hard to advocate for yourself.
Yeah.
And I mean, I'm a healthcare provider, and even when I'm the patient, I find it hard to speak up. Like, even though I know stuff, it's still hard. Yeah.
Yeah, let's branch into like how you view some of like PCOS and infertility when you have a new client come in. And just kind of, if you're cool with it, just use this for us to learn and for the audience to kind of learn what kind of scope you're viewing things at and what type of care you want to be giving these people to obviously achieve their outcome, whether it is be able to have a child, be able to just like feel better and function better in their day-to-day life.
Yeah.
So you already PCOS is a tough one. It is hard to diagnose, plus treatment in terms of what you're going at. I guess, let's just explain what PCOS is medically, and then kind of signs and symptoms, and we can just go from there if that's cool, Lisa.
Yeah, that sounds good. So PCOS stands for polycystic ovarian syndrome, which back in the day, kind of the main diagnostic criteria that they would look for on a vaginal, pelvic ultrasound was if your ovaries had multiple cysts on them. There's a string of pearls is how they describe the appearance. And that's, one of the possible diagnostic criteria for PCOS now. We follow, it's called the Rotterdam criteria. You have to meet 2 out of the 3 criteria. So polycystic ovaries on ultrasound is one of them. Hyperandrogenism, so high testosterone or higher levels of like the male type hormones, either on blood work or with clinical symptoms. So usually that'll be like increased facial hair on the chin. It's not just the peach fuzz, it's like the thick, coarse, dark facial hair, or struggling with really bad acne is another sign. Hair thinning from the top of the head, like male pattern baldness, can present also. So those are 2. And then the third one is like irregular menses. So going long periods of time without your period. A lot of people can go months and months and months and only have a couple periods a year if they have PCOS. So you have to meet 2 of those 3 criteria to be diagnosed with PCOS. That can be tricky sometimes, just depending, because I think for a lot of people, their symptoms can fluctuate, and it depends on like how stressed they are, what their diet and, exercise, sleep has looked like in the past couple months for how they then present to you. So I need to get like a full scope picture of what's been going on. Like when you first got your period, how long was it normal, if it ever was? When did it show up? When did it start to become abnormal? Can you think of anything else that, you were diagnosed with around the same time that all this started? Is your thyroid, functioning correctly? What's your blood sugar looking like? Do you have an elevated A1C? Are you pre-diabetic? There's like a whole, it's a very metabolic type syndrome, not just reproductive. And those 2 systems are very closely tied together.
Because it's play on insulin sensitivity as well.
Yeah. So if you have PCOS, you are more likely to have issues with insulin resistance, which is, going to affect your blood sugar, and it's going to affect how well your cells are bringing sugar into them to function properly. And if you have insulin resistance, that also then has a downstream effect on your hormones.
Right.
And you're usually producing more androgens, which then it's like a vicious cycle. It kind of feeds back in on itself.
And then is there downside too of somebody who's dealing with these symptoms and then they're going towards like caloric restriction or real high intensity training, and that's kind of elevating cortisol and feeding some of these things, or no?
So something I learned actually pretty recently was about how people with PCOS are at higher risk for sleep apnea. And then if you're sleep deprived, that kind of increases your cortisol and your stress on your body and increases your risk for insulin resistance. So that's a, feedback loop. And then, there's some interesting studies on types of exercise that can be beneficial for PCOS and then might actually harm people with PCOS. And the evidence is actually kind of mixed. Like some research shows that like high intensity workouts can actually be really good, while others show that it's not helpful. So that's where like the personalized approach is really important, because I've heard patients tell me, I feel really bad after I do high intensity exercise. So then obviously your body's telling you something like, high intensity is usually really good if you get the endorphin rush and you're sleeping better and you're finding that you're losing weight. But if it's making you sluggish, you're actually gaining weight, you feel stressed out all the time, like, don't do it. So
Right.
yeah, it's a lot of personalized approach is important for sure.
Can it be helpful if girls can start to figure out, like, get a diagnosis at a younger age to be able to address some of these things?
Yes. And what you often see is that they were just put on the birth control pill because when you're young and you're going to school and you're having really irregular periods that show up out of nowhere and you're like bleeding through your clothes at school, that's going to be the main issue. Especially if you're still going through like puberty, your body's still growing, you can't really, you don't have as many obvious signs that something else could be going on. So it's really just the periods are like the main focus. Like when I see young girls and their moms come in, that's like the main complaint. So, historically it's been, okay, let's put you on a birth control pill because that's going to make your periods more regular. It's going to help you know when to expect it, that it's coming. And, the birth control pill does actually help to decrease the amount of free testosterone in your body. So if you are struggling with facial hair, a lot of people do find that the pill helps improve that. But what's important to know is that's just a Band-Aid. It's
Right.
not actually solving
Like
anything.
in your head, what are, and I'm sure it's different for everybody, but pros and cons of we can use it with PCOS, for example, of being on the pill over time.
Yeah. I mean, just feeling empowered to know when you're going to start bleeding is huge because that's like such a headache and a nuisance and embarrassing for people. So like having that feeling of control is really helpful. Obviously, if you're trying to prevent a pregnancy, that's important and useful. And, some people do find it helps to make them feel better. It helps to get rid of the facial hair. Some people find, if you have like really bad PMS or premenstrual dysphoric disorder, if you get really depressed and anxious before your period starts, which we do see a lot of that in people with PCOS as well, the pill can sometimes help alleviate those symptoms. But then when you're on the pill from age 12 to 30, when you're finally ready to start building your family and you come off of it, then it's like we got to start all over kind of and like identify, is it actually PCOS that was causing these irregular periods? Is there something else going on? And then it's like a whole thing.
Right.
And they're like, I want to be pregnant now. And that's just not possible.
Yeah.
Yeah.
When it comes to people coming to you for, I guess with PCOS, then where have you seen success? I'm sure it's so individualized, but where's your head first? What's lifestyle? What's diet? What's exercise like?
And I do, that is a shared decision thing that I talk about with the patient. Like, what is your immediate goal? Is it to get pregnant? Because depending on the timeline, I might just be referring you to an IVF clinic.
Right.
If that's like the immediate thing. If they just really want to feel better and have like fertility optimized for the nearish future, then I ask, how motivated, how like ready are you to make changes in your life?
Yeah, you spend so many years just like avoiding wanting to have a kid. That was our story, right? So many years, and then you start to try, and it's just like, oh, this is much harder than I thought it was going to be.
Yeah.
I've just seen that with our ex who ended up doing IVF for our daughter. But it's just like, so many years, like, I don't want to get pregnant. I don't want to get pregnant.
And
then you're like, oh shit, this is not easy.
It's crazy. And then you see all these people around you having babies instantly, and then it just kind of exacerbates this like urgency too. It can be really hard. Yeah,
my wife's she's had to, when we were, trying to get off of social media because you're just seeing all of your friends and family members have kids, and it's the psychological side is huge.
It's very isolating for people.
Okay, so diet, exercise with PCOS. What other things have you found that have been helpful for women?
Yeah, I mean, sleep is a really big one that I ask people about. If they are getting 4 hours of sleep a night, we need to figure that out. A lot of people who work night shift, obviously you can't just say, well, quit your job and get a new one, but like we really need to make sure we're allowing for them to get adequate sleep during the day, and helping them, find what that means to them, whether it's doing a mindfulness meditation before bed, if they need to be exercising a bit more, just to help get their body ready for sleep when it's not necessarily natural. Stress is a big one too. Like, obviously, if you're under chronic stress, that's going to mess with your cortisol levels, and your cortisol has direct impact on your reproductive system. Evolutionarily, if you're, if your body is under extreme stress, you're going to shut down functions that aren't necessary to survive. And if your body's thinking you're under some kind of extreme danger all the time, it's not going to want to reproduce. So just looking at, all functions and aspects of life that you do have some control over, and just diving into all of those aspects.
So that, and then also you have clients with endometriosis as well. Do you view that similarly, or this is a different thing in terms of hormonally and the path you're taking to health?
That one's even trickier because we still don't have a clear picture of like where endometriosis even comes from and how much lifestyle can affect it. Like, at least with PCOS, there's a decent amount of data that's come out somewhat recently about avoiding high processed foods, getting enough protein, all of that kind of stuff, what kind of exercises might help. But with endometriosis, there's not as much data available. So it's kind of like looking for anecdotal data, doing trial and error with individuals, and then, assessing like what are your main goals for the near future. There's like a lot of stuff coming out recently that I've seen about like potential environmental toxins that can make you higher risk for endometriosis, like mold in your household as a child. And then there's theories about like retrograde menstruation and how that can cause endometriosis, where basically when you're having your period, some of the cells from the inside of your uterus actually flow back up into like your abdominal cavity and can then implant. Because that's what endometriosis is the cells that are usually found inside of your uterus are found outside of the uterus.
So like where what my wife ended up doing before rounds of IVF for our daughter was having to go to Boston for excisions surgery. And you name, something in her abdominal cavity, and there was endo tissue on it.
So that's really tricky because not everyone has access to a nearby doctor who's trained in that surgery.
Right. And she was so proactive to get to that point. Like, I think if she just went the route around here, they would have. What's the other procedure where they burn it?
Like a cauterize it?
Like that would have been the recommendation if she was around here. But knowing the long-term outcomes weren't great with that, it was like, now I have to figure out what the kind of gold standard is, and then who does that, and then who does a lot of that and is really good at it.
Yeah. It's really hard.
It's tough.
Yeah.
It's tough for sure. So those two are two of the primary things you see then. You get into like, and everything's so multifactorial too, because we talk about environmental toxins and food and lifestyle. That can be very overwhelming to people. It
can, and that's why I like getting into the mama coach. What was appealing about kind of having my own way of practicing was like giving myself like a 90-minute intake with someone so that we can like get into give me like an example of what you eat throughout the day. Like, what time do you go to sleep? What's your pre-bedtime routine? How do you wake up feeling in the morning? And like, that's stuff that your normal provider doesn't have time to ask you.
Right.
Yeah.
Yeah, it's true. But people that see you with a mama coach, they're probably being more proactive anyways, that they're seeking out your services.
That's kind of been nice in a way, that my patients like self-select, because I am really passionate about the lifestyle stuff. And occasionally at their practice, I'll get patients who just aren't interested in hearing about that for whatever reason. They're probably overworked or, too stressed out from other stuff going on in their life that they just don't have like the energy to focus on that right now. So when I get patients at the Mama Coach, they have heard my approach and that appeals to them. So it is a bit easier to like actually practice that way because they're open to it.
Yeah, having that pre-screening process almost is nice, because then it makes it an easier transition.
Yeah, definitely.
Especially because I'm sure those intakes are, at times for people, can be like emotional if you're talking about lifestyle and stuff like that. So
it's very true.
Dives into deeper parts of their life.
Yeah. What's something on your intake that like, or I guess, what are early signs that are probably missed in terms of PCOS, endo, if we're talking about those right now with women?
Yeah, I mean, the irregular periods are, like I said before, kind of the most like obvious, maybe first thing a person or a provider would pick up on. And that usually either presents like with PCOS, only getting your period a couple of times a year, or with endometriosis, like extremely painful, heavy periods. But so many women have been told that that's normal. So the next thing I'll ask, especially with like younger kids or, missing school, and then older adults, are you missing work?
Right.
Or are you feeling like you're missing out on like social activities, or is your relationship suffering because you're always in pain? Stuff like that. And then, looking at anything else that they feel is like getting in the way of them living their best life, whatever that looks like.
Right.
So I kind of leave it more like open at the beginning of them telling me their story. And then I'll kind of have my checklist of symptoms that I know to look out for. And then often I'll say, do you have this? And they're like, oh yeah, I honestly didn't even realize that was abnormal.
Right. The supplement industry is like the Wild West. The lack of regulations mean the supplements you purchase may not even contain the ingredients listed on the label, which is why I get my daily vitamins and supplements from Thorne. Thorne vitamins and supplements are made without compromise. Quality ingredients ensure your body optimally absorbs and digests your daily supplements, while in-house and third-party testing ensure you're getting exactly what you paid for. Thorne offers a variety of health tests reviewed by board-certified physicians that evaluate your lifestyle, gut health, sleep, stress hormones, and metabolic markers to determine which vitamins and supplements may be most effective in helping you feel and perform better throughout the day. For college and professional athletes, Thorne has NSF-certified supplements that make sure you won't get pop positive on a drug test. Whether you're an athlete, professional, parent, grandparent, or weekend warrior, Thorne's selection of high-quality supplements can help improve your quality of life. Switch to Thorne's high-quality and extensively tested supplements today at thorne.com/u/CDSF. That's thorne.com/u/CDSF. This episode of Off Exit 10 is brought to you by Mark Pro, the recovery tool of choice here at CDSF. Mark Pro is a portable, easy-to-use muscle stimulator we utilize to enhance recovery, prevent overuse injuries, and ultimately boost the performance of our athletes and active adults. Unlike a traditional TENS unit, the Mark Pro doesn't just mask your pain. Its patented technology works to improve circulation, flush lymphatic waste, and reduce soreness. The Mark Pro and Mark Pro Plus are used here at CDSF and trusted by players and trainers from all 30 MLB teams. Plus, the Mark Pro offers US-based one-on-one support for whenever you need help with how to use or when to use your unit. So recover like a pro by heading to markpro.com and using code CDSF for 10% off of Mark Pro, Mark Pro Plus, or Boost Pro Massage Gun. That is markpro.com. Use code CDSF for 10% off your order today. And then just been looking at intake, you know where you want to go at first, whether it's going to be sleep, whether it's going to be nutritional changes, whether it's going to be, we'll get into perimenopause and menopause, but hormonal protocols.
Yeah. And again, it depends on the person, what they feel is possible to change at that period in time, and how motivated they feel to address it. So a lot of people feel like they want help with their nutrition. So then with the Mama Coach, I do a lot of like meal prep ideas, and I'll say, what kind of foods do you not like, so I can avoid those. And then I'll give them like a grocery list, and then snacks, lunch, meal prep for work, dinner ideas that have enough protein, enough fiber, enough vitamins and minerals, just because who has the bandwidth to come up with that? If you're used to going out to eat or picking up McDonald's or Subway, like you're not in that. It's a habit that you have to form. And that takes a lot of time and energy. So if I can help them just like, here's your grocery list. That's at least one part that's like taken care of.
Yeah. And you got to meet somebody where they're at
to
be like, I can't just overhaul you. It's going to be too much and you're not going to adhere to what I'm giving you.
So the goal setting is a big thing of, a big part of what I do is like 1 week at a time, we'll set like one main goal, whether that's, food, sleep, whatever. We'll see how it goes. And then the next week, if we just need to keep that same goal, we'll keep it. If we feel like we can add something in, then we'll add something in.
What's kind of a common thread? Lack of protein?
I feel like, more recently, protein has been getting some attention on social media. So people are a bit more aware of how important it is. I feel like fiber, people are eating so many processed foods. They're not eating whole foods anymore. So the fiber is just non-existent in a lot of their diets.
This is Sam, my wife's a dietitian. She would love this because we talk about the fucking RFK flipping the food pyramid. And she's like, fiber's still important. Like, it's still a very crucial part of people's diet.
Yeah. And, fiber, actually, I didn't learn this in school. I had to learn this on my own fairly recently. But fiber can help rid your body of excess estrogen. So, like, for people with PCOS or endometriosis who are really struggling, increasing fiber can actually help alleviate some of the symptoms and help bring your menses back to, like, somewhat normal. So, it's not just for your bowel movements and cholesterol and all that kind of stuff, but it can actually help with hormonal balance too. On
the hormonal front, because didn't they just, on the RFK train, he can't get rid of the black box warning, but just kind of brought to light that, hey, like, hormone replacement therapy is safer than what it turned out to be.
Yeah. So the big study that kind of freaked everybody out about hormone therapy was in the early 2000s, and that was the Women's Health Initiative study. And that was looking at two specific hormones that we don't typically use anymore in HRT, but it was like conjugated equine estrogen. So that's actually derived from horses, like a horse estrogen, and then medroxyprogesterone acetate, which is a synthetic progesterone. So the first thing to know about the WHI was that it was cut early because we were worried about increased risk of breast cancer.
And this study was when, early 2000s?
Early 2000s, yeah. So, you'll hear about it in a very dramatic way, and I guess it was very dramatic, but like all these women were on HRT, and then the study came out, and they had to cut it early because everyone was worried about breast cancer and blood clots. And I guess like the phones were just ringing off the hooks at all these doctors' offices with people being like, do I need to stop taking this? So it was very like emotional and really scary for people because they felt like they couldn't trust what their doctor had told them, basically. But what we now know is that the results of that can't really be applied to what we're doing today. First of all, the average age of a woman in that study was 63. So she was well past menopause. The average age of menopause here is 52. And that counts as going one full year without a period. So women were being put on hormones that their bodies hadn't seen in like over a decade. And we know if you're coming off of estrogen, or if your ovaries are starting to shut down, you're going into menopause, your body obviously senses those changes and then kind of adapts. So if you've adapted to being without estrogen, then all of a sudden you're put on it, like that's not good.
Yeah.
So that's a big thing, is the age of women in that study, the types of hormones that were used in that study. We don't really, the medroxyprogesterone we do still use sometimes, but we've just learned and have come up with a bit safer forms of hormones. And then the way that the study findings were conveyed was actually not, they were kind of blown out of proportion. So like the rates of breast cancer, they were given in a way that made it sound like they really increased your risk by a very scary amount, where in reality, it was only a couple extra cases per like 100 women. So kind of like an absolute versus relative risk thing, where the reporting was just like kind of misunderstood in terms of, how they presented the data.
And that just created this fear of like, I don't want to go on this. It's going to increase my rates of breast cancer, blood clots.
Those kind of are the two main like really scary things that are still theoretical. The risk is there, but they're way lower than we thought, and then even lower now with certain formulations of the hormones. So like I personally like to use the estradiol, which can come in a patch. There's a pill, there's a vaginal ring, and then the micronized progesterone. So those are, and we can talk about what bioidentical means. But those are the more, they're structurally identical to what your body is already making. So there just seem to be much lower risk for all of that kind of stuff.
Yeah, and we'll go, so before you get to that point where you have to make this decision, like, am I going to have a woman go on HRT or not? they're needing that because their estrogen and progesterone is decreasing as they hit perimenopause and get into menopause.
Yes. So so perimenopause is the transition phase from where you're having, in your young reproductive life, you're having regular menstrual cycles, you're ovulating regularly, you're having like this normal increase and decrease, normal fluctuation in your hormones throughout the month. Perimenopause is when that starts to be disrupted, and it's usually pretty subtle at first. You can maybe skip a period or start to have occasional mild hot flashes. Symptoms can start out really vague and mild and then can increase over time. But as your eggs essentially as your ovaries essentially are running out of eggs, the hormone from your brain that triggers your ovary to ovulate, that starts to increase because your ovaries aren't responding like they used to. So your estrogen levels are fluctuating quite a bit in perimenopause because 1 month you ovulate and you're, making plenty of estrogen, and then the next you're not ovulating. So the FSH from your brain is like screaming at your ovaries and there's no response. So your estrogen, goes up and down quite a bit in perimenopause. And as you start to ovulate less and less, your progesterone levels decline as well. Your testosterone levels decline, but your cortisol, your stress hormone, actually really increases, and people can feel that very strongly.
So you have this fluctuating estrogen up down each month, but over time, those up downs, it's steadily going down.
Yeah.
I guess let's go through symptoms then, which then puts somebody in a spot where you go, wow, your quality of life is decreasing so much, you feel so poorly every day, where it may be worth it to go on a hormone replacement therapy.
Yeah, and it can look really different from person to person, but the main, most common symptoms you'll hear, the hot flashes, the night sweats, trouble sleeping, night sweats aside, if they can't fall asleep or they're waking up throughout the night or waking up really early in the morning and can't fall back asleep. Mood changes. I hear a lot of women say, I feel crazy. Like I'm yelling at my husband for no reason. I'm like on edge all the time. I'm very irritable. I'm very anxious. I've never had anxiety before, or I'm just, depressed for no reason. A lot of fatigue, like a low energy, low motivation, brain fog, trouble concentrating. A lot of women have like mysterious joint pain and muscle pain that they've never had before and can't figure out why that's happening. So the list goes on.
Yeah, I think, and us, right? Like we are, my wife's dietitian who's on staff, but just these people for nutrition consults. But we're a staff of 5 dudes, and we have more women here than we do men. Mm-hmm. Oh, yeah, for sure. I think both in our general population and our athlete, high school, college population, Paul,
Yeah.
Nice.
Yeah.
For sure. Like definitely have more women.
And something we hear a lot with our general population, women who are going into perimenopause is I think, Paul, you can probably say, you hear this too, is I've been doing everything that I used to do. I'm eating the same, I'm training with the same intensity.
Or training harder.
Yeah.
But yet I'm gaining weight, I'm feeling worse.
Mm-hmm.
Yeah.
Common thing you hear.
Oh, yeah.
I guess it's just explain hormonally how that makes sense. Like why that's the case. Their nutrition, let's just say that it's good, is the same. Their training intensity is, Paul, you're right, the same or if not more, because they're like, I need to.
Right, like they've started to either go to the gym more or work harder than they did before. Or in theory, work harder than they did before, or do more high intensity because they're not sure like what else to do. And so they're almost in this like silo. Is the way
hormonally explain why that makes sense when you hear that.
So the first thing I say to people is your hormones have you have hormone receptors all over your body. You have estrogen receptors in your bones, your muscles, your heart, your brain. It's not just with reproduction. So estrogen, when you're cycling regularly, when you're in your young reproductive years, the levels of estrogen that you have in your body kind of help with lipid metabolism. They help with blood sugar regulation. They tell your body to store fat like around your hips, thighs. Once you're in perimenopause and postmenopause, the drop in estrogen really disrupts how your body normally processes calories, how it helps you form muscle, how it helps your bones. So people will notice like, I hate this term, but the spare tire, where it's like you have this fat accumulation around your waist. It changes. It's not in your thighs and your butt anymore. It's around your waist. And that's like very noticeable for people and can feel like really scary because I hear people say all the time, I don't feel like this is my body anymore. Like I'm in someone else's body. And that can be like really scary, especially if you don't know why.
Right.
But it's your hormones, like it's estrogen.
It's the decrease of estrogen.
Yes, the decrease of estrogen. And that just like, it changes, how you process food, basically, and where your fat is stored. It increases your risk for type 2 diabetes. It affects how sensitive your cells are to insulin. It's a whole like metabolic process that's happening that people, there's just no education about it.
So before HRT, though, are there ways where you can dull some of these effects, or I get you can't stop the estrogen from going down
without
over time.
Going on supplemental estrogen. Yeah, you can't stop it, and that's like a really important piece I try to drive home is like this. It is natural. Like I don't want to diminish their distress over it, but like it is natural.
Right.
That this is how it's going to go. Let's just kind of embrace. And I'll say, try to focus less on how your body looks and more on how you feel and what like your blood work is showing. If your cholesterol is good, if your blood pressure is good, if you have decent energy, like those are really the most important things. And then we can, then focus on body image and all that kind of stuff. So just like, yes, this is normal and this is why it's happening is like the first key. But then understanding, how we can optimize or reduce the extremity of how far this can go for people. So adequate protein is a big one, adequate fiber, and then maybe looking at how they're exercising and figuring out if we need to be adding in more strength and resistance training.
And they both help because in the hormonal standpoint, increased protein and fiber.
So they help. So protein especially helps build muscle. Once you're in peri and after menopause, the lack of estrogen makes it harder for your body to maintain your muscle mass, your lean muscle mass. And we know the more muscle you have, the faster your resting metabolism is. So the more efficient your body is going to like process calories, basically. So if we can increase the amount of muscle you have in your body, the more efficient your metabolism is going to be.
How important is it when you're in your younger years to bank muscle tissue, to bank bone density so that you're dealing with this less?
Yeah.
Is that true?
It's important to bank, but you have to know just if you bank when you're young, it doesn't mean you're like saved when you're older. Like you still have to keep doing it.
Right.
Yeah.
Right. But
You can't retire.
Yeah.
Can it stave off some of these effects though?
Yeah. If you're starting at a higher reserve, the loss is going to be, it takes longer to get to the point of like osteoporosis, for example, with bone density.
Right.
If you have stronger bones when you're younger, you have farther to go before you get to the disease. Whereas if you aren't, your bones are frail when you're young, obviously they're going to be even more frail when you're old.
Yeah.
But let's say you didn't resistance train when you're younger years. Now you're realizing the importance once you've hit perimenopause.
Yeah.
You still can be
do it.
okay.
Yes.
We're still going to do it, and it still is going to have benefit, even though it's harder because of the lack of estrogen.
Absolutely. Yeah. Yeah. I would never say it's like too late unless you're like, you can't move without falling over and potentially
now
like
we have
breaking it.
we have a safety
Now
issue.
now we have other things we got to deal with.
Yes.
Right. So that's a big thing then, resistance training. Your protein intake, your fiber, any other things in terms of before you get to hormone therapy that you're thinking about?
I mean, just making sure people are eating enough and like focusing on the really beneficial stuff. A lot of women, especially when they start to put on weight, they start to count their calories.
Yeah, and they're restricting.
And might restrict. And that's, if you're underweight, that's not good for your muscles or your bones.
Right.
So yeah, making sure you are fueling your body effectively so that you can then work out and actually do the stuff that's going to help. Yeah.
Okay, when in your head then are you, or this whole time you're making the decision to, I think hormone replacement therapy is going to be very beneficial for you, not for everybody, but what factors are you weighing to say, okay, now I think is an appropriate time? Is it when somebody has addressed all these other factors, or already doing that, or you feel like, hey, you're kind of so far along the way where just to be able to maybe feel good enough to get in the gym, we need to do this?
I think the latter
Is more often?
More often, because it's more, for the majority of people I see, especially if they're already working out and eating well, it's not a question of like, what are you doing wrong? It's more just like this natural process is really affecting your quality of life, and you are like crying in my office because of everything that's going on. You don't feel like yourself. Like, that's a problem. So the majority of the time it is more like quality of life. And then, if we can get you back to sleeping 8 hours a night and give you back your energy, then that'll motivate you even more to go to the gym. So I think just feeling more like yourself and feeling a bit more in control is like the first step. And most women are candidates for HRT. There's a couple contraindications that we have to consider. If someone is prone to blood clots, estrogen, that's a conversation that we need to have. If someone is actively dealing with breast cancer or has a recent breast cancer history, that's something that we need to consider. But most healthy women can handle HRT, especially with the safer formulations nowadays. So if they, are having even just a couple symptoms and they're curious about it, like, I'll talk to them about all the known benefits, the known risks, and then we decide together if it's something they want to do.
What are the safer formulations now than prior, say 20 years ago?
Yeah. So the estrogen component, now the most common one, the one that I am most comfortable using, is estradiol.
Because you have 3 or 4 types of estrogen.
So there's 3 main types of estrogen. And the most, like, the one that we are most familiar with, the one that's like the most important or most active, especially in the reproductive years, is estradiol, E2. And so, when we were doing the WHI, we were using this like other form of estrogen, and that form seemed to be much higher risk for things like blood clots. Whereas estradiol, it's bioidentical, so it is the same chemical structure as what we are making in our bodies. That's now an FDA approved drug that you can prescribe. So there's different forms that it's available in, but we know that when you take a hormone through the skin, so transdermally with like a patch or a gel, it bypasses something called the first pass effect, which is where when you take something orally, it goes and is processed through your liver. And when estrogen goes into the liver, that's where we get a bit more concerned about, well, first of all, potential liver inflammation and liver disease, but also clotting factors. So when you bypass the liver and you take it through the skin, the risk for something like blood clots with an estradiol patch is extremely low. So that's like my first go-to. And people seem to tolerate it really well. And there's a big range of dosing that we can start out with pretty low and then taper it up if we need to. And then the progesterone component. So if someone has a uterus still, if they haven't had a hysterectomy and they are after, post-menopause or even still menstruating, and we give them this exogenous estrogen, we're stimulating the lining of their uterus to grow. So that's normal if it's coming from inside your body and it's just part of a normal menstrual cycle, because then you shut it with your period. Mm-hmm. But if we're giving you all this estrogen, it does increase your risk of endometrial cancer because it's proliferating those endometrial cells kind of in an unchecked way. So we have to give progesterone, which then keeps that growth in check, basically, and it brings you back down to an average risk for endometrial cancer. So the progesterone component is mainly for endometrial protection, but it can also help with sleep and hot flashes and mood for some people. But micronized progesterone is the FDA-approved bioidentical form of progesterone. So it's suspended in peanut oil. So for people who have peanut allergies, they can't take it, but it's very well tolerated also. And it's just a pill that you would take either half the month or every night.
So you're always taking estradiol and progesterone?
Unless you don't have a uterus, then you can only take estrogen unless there's some other reason that you need to go on a progesterone.
And that then, if you're just taking estrogen, increases your rate for endometrial cancer, or no?
So if you have a uterus.
Oh, if you don't have a uterus, then yeah, right, that's out of the picture.
Exactly.
Right? That makes sense.
Yeah.
That makes sense. And you're always starting with transdermal.
That's my preferred go-to. Everyone has a different practice, but just based on the safety data, that's kind of my first go-to.
Yep. What if a woman is into menopause? Like you said, with the earlier studies, these women were in their 60s when they were starting. Do you still feel comfortable starting somebody then or less versus if they were in their 40s or 50s?
Yeah, the timing hypothesis is kind of what we got out of the Women's Health study. And now we have a lot more data on kind of the best time to start someone on HRT. And the best time seems to be while they're still transitioning, while they're still in perimenopause, or in the first 10 years after their final menstrual period.
10 years.
Yeah. So, if someone had their final menses at even a little bit later at like 55 or something, and now they're 61, they're still within 10 years. And if they're really struggling, I'll have that conversation with them. But the general rule is either under 60 or within 10 years. Yeah.
So the estradiol E2, what's E1, E3 then?
So there's estrone and then estriol. Let me see, I have to look at my notes.
Yeah, pull up. You're doing great. It's your first time going to the notes.
Yeah.
Look at you go.
So estrone is E1, and that's the dominant form of estrogen after menopause. And that's usually found from like your adrenal glands or adipose tissue, so fat tissue. And then estriol is E3, and that's the main estrogen in pregnancy.
Okay.
Yeah.
Okay, that makes sense. What blood work are you looking at when you're working to make these decisions?
So that really depends. If someone is like fully up to date with their primary care, they've had a recent like liver panel, recent CMP to look at like cholesterol and all that kind of stuff. Recent TSH to confirm that their symptoms aren't coming from like a thyroid dysfunction, recent vitamin D levels, all that kind of stuff. A lot of people will ask me about testing hormones, and that's kind of a nuanced conversation to have. If they're still getting periods, but they're struggling with symptoms of perimenopause, testing their hormones can be a little bit tricky because when we test with blood work, because your hormones are fluctuating so rapidly and so erratically, when we get a level from you, that's just giving us that snapshot in time of what's happening. So also, even if we test your blood work today, it might come back normal, and that's not really going to help us with anything.
Right.
We might get lucky and catch it on a day where it's high, and that can kind of confirm what's going on. But if you're like mid to late 40s, early 50s, you're having all these normal kind of perimenopausal symptoms, testing your hormones isn't really going to tell us that much information anyway. So it's good to rule out something else, but then checking like your FSH or your estrogen, there's not really a ton of reason to do that. So usually with HRT, it's more symptom-based for how we decide the dosing. It's not recommended unless we're doing something like testosterone replacement. It's not super helpful to keep checking your blood work. Like if you're feeling really good on a low dose, we'll just keep you on the low dose.
Right.
Yeah.
And then if somebody says, I'm feeling better, but not much, you go, I'll just increase
taper it up a little bit. Yeah.
Just
Yep.
little boost,
Yeah.
What's a scenario a woman would go on testosterone replacement?
So, yeah, that one's tricky because there's still not an FDA approved formulation for women in the US, but there's plenty of data supporting the safety of testosterone if used appropriately. And some of the benefits, the main one being sex drive. So a lot of women in peri and postmenopause are really struggling with decreased libido, and that's causing issues in their relationship and et cetera. Causing distress on themselves. So testosterone replacement has been found to help with that. And it can also help with muscle loss, energy levels. There's other stuff that it can help with, but kind of the main focus right now in research is libido. Mm-hmm. And that's why most women who come to me asking for it are asking for it. But because there's no appropriate formulation for women yet, the dosing can be very tricky. So they often recommend getting a baseline testosterone, baseline blood count to look at like hemoglobin and hematocrit, because going on testosterone can affect like your red blood cells basically. So making sure that we kind of know where we're starting at, and then starting on, usually we use a transdermal gel, and you'll just use like a tiny amount, like 0.5 meter dose pump every couple days. And we'll do that for a month or two, and then get a second testosterone level and make sure we're not like overdosing you. Yeah. And we can kind of taper that as needed.
This episode of Off Exit 10 is brought to you by Bombas. Bombas makes my favorite pair of socks, hands down, alongside the most comfortable and durable underwear, t-shirts, and other everyday clothing staples. Their wide variety of sock lengths, colors, and patterns have you covered, whether you're working out, going out, or lounging at home. I love their merino wool blend athletic ankle sock for long days of coaching at CDSF and getting in workouts myself. And if I'm at home doing work around the house, you better believe I'm wearing my Bombas Sunday slippers with their comfy memory foam midsole. And when you buy from Bombas, you're also buying for those in need. For every item you purchase, Bombas donates one item to people in overnight shelters, transitional living facilities, rehab centers, Title I schools, and medical service professionals. Take my word, if you want to upgrade your sock game to one that's more comfortable, durable, fashionable, and charitable, head over to the Bombas link in this episode's description to browse their full collection of everyday wear, and don't forget to use code CDSF20 for 20% off your first order. This episode of Off Exit 10 is brought to you by Anchor and the all-new Anchor Pro, crafted to endure the most high-performance workouts without the high cost and space requirements of a standard cable machine. Named the best portable cable machine by Men's Health Home Gym Awards, Anchor provides the full functionality of a cable machine in one small space-saving unit. Designed with user-friendliness in mind, Anchor can simply be attached to any squat rack or placed on any wall in your home gym using its intuitive sliding track mount. With up to 65 pounds of resistance, Anchor is built for high speed and controlled exercises alike, from cable presses and rows to chops and lifts. The Anchor has been a game changer for us here at CDSF, and now you can enjoy the same professional quality cable machine in your own home gym by heading over to anchortraining.com and using code CDSF10 for 10% off your order today. Get all the benefits of a cable machine without the high cost and installation fees. Enjoy the portable luxury and space-saving performance of Anchor today by going to anchortraining.com and using code CDSF10 at checkout. That's anchortraining.com, promo code CDSF10 for 10% off your order today. This episode of Off Exit 10 is brought to you by Drink Alchemy. Fatigue and brain fog affect us all, destroying everything we pursue. Whether as an athlete, artist, creator, or entrepreneur, our mind holds the key to performing optimally. By combining the most potent organic nootropics found in nature, Drink Alchemy delivers sustainable boost to creativity, memory, energy, and focus in one epic beverage. Stop pumping your body full of excessive amounts of caffeine and unknown proprietary blends from other energy drinks, and get clean energy from Drink Alchemy's natural nootropics like lion's mane, L-theanine, and caffeine from green tea. Used by Olympians, D1 athletes, MMA fighters, and entrepreneurs, Drink Alchemy has become a huge part of my daily routine, making sure I'm functioning optimally during long days of coaching athletes, running CDSF, and getting in quality workouts myself. So do yourself a favor and ditch the energy drinks loaded with caffeine, other stimulants, and who knows what else, and head over to drinkalchemy.com today. Live with your mind unbound and save 10% off your order by using code CDSF at checkout. That's drinkalchemy.com, promo code CDSF for 10% off your order today. Yeah, and then okay, because everything you're talking about, even the estradiol and progesterone, that's all FDA approved. Mm-hmm. What about when we get into, because there are, is that what the bioidentical is? That is just like a supplement, non-FDA?
So yeah, the term bioidentical like means one thing, and then people use it in a different way. So bioidentical means it's identical to what you biologically make in your body. And there are the FDA-approved estradiol and micronized progesterone forms of that. But it's kind of being used as like a marketing term where if people don't know what's available to them, they'll kind of prefer the more like natural form.
Which is the non-FDA regulated.
Which is from compounding pharmacies that are not FDA approved. And there are reasons why someone might need to use that if they have like an allergy to an additive that's commonly put in the FDA-approved formulations. But yeah, a lot of times the reason that we don't typically recommend compounded hormones is because they're not regulated. So you can't confirm the dose that you're getting. and you can't
confirm what's in it
exactly.
all the way.
Yeah.
Right.
I mean, we deal with supplement talking here a lot, and we try to refer out to my wife as much as we can.
Yeah.
But it's like people have to know that the supplement industry, and this would fall into it, is not FDA regulated.
Nope.
Yes.
So marketing can say whatever it wants to say until they get sued, and then they have to change course.
Yeah.
And you don't know what is in a proprietary blend.
Yeah.
Well, and you might be thinking you're getting one dose, and then
then you're getting like double or triple that.
or you're not getting the same. Then you're like, then you think you need to get more,
right?
But it could be this whole shit show.
Exactly. It's impossible to know what you're getting. So a lot of times women will come to me and say, well, I want the bioidentical one, and that means something different from what they thought it meant, basically.
Right.
Yeah.
Because you're saying the FDA ones are also bioidentical. They're just FDA regulated versus not. What are the non-FDA regulated forms coming from?
So, like, you mean where the hormones being made?
What is it?
Natural
made up of?
sources, which is like yams. I know is a big one for the estradiol. Plant, other plant forms, but they're put into like a lotion or a cream or a lozenge. And another reason people like them is because you can ask for like really specific doses that you might not necessarily need, but it is appealing for whatever reason. Or you could get your estrogen, progesterone, and testosterone all in one, which is nice too. But you can't confirm what you're actually getting.
Can't confirm nor deny what is actually.
So you're almost always recommending the FDA one unless somebody has an allergy to something.
Yeah, which I honestly like. If they have an allergy to peanut oil, I'm still going to prefer an FDA approved, even if it's a synthetic progesterone.
Right.
And we'll just go over. I'll make sure they know the potential risks that come with that. But usually they're on such a low dose of it.
Well, and the risk of knowing what's actually in it versus what's
exactly.
not in it. What risk do you want to take?
Right.
Yeah. That's like with college athletes who higher level ones who are going to get tested or professional. Like we'll make sure stuff is NSF just because at least it's been third party tested. So you may not pop on something where you're like, I didn't take this.
Right.
Yeah.
Just because things aren't regulated.
Yeah, it's scary.
Yeah. So I guess, your pitch to a woman who maybe their mindset is still based around this, who did the study?
The WHI
from the early 2000s of like, oh my gosh, I'm feeling terrible. I'm not having the quality of life that I want because of this change in my hormones, but I'm fearful of taking this hormone replacement because I'm afraid of increased risk of cancer and clotting. What's kind of your pitch to make them feel like safe and hey, this is really going to be helpful for you?
Yeah, I mean, I kind of start from the beginning and talk about the study and talk about, you're 50. The women in that study were in their mid 60s. We have different formulations now. There's so much data supporting the safety of like the transdermal estrogen and the micronized progesterone. And then the breast cancer thing is a big one. So I'll kind of explain how they portrayed the risk versus what the risk actually was. The actual risk is a couple more cases of breast cancer per like groups of 100 women, but that was portrayed in a way where it sounded a lot scarier, like a 90%. I don't remember the exact number, but it sounded like way scarier because they portrayed it in the relative risk versus the absolute risk.
Right.
So just explaining that and saying, I prescribe this multiple times a day. I have yet to have a patient who's had a severe adverse reaction to it, just anecdotally from my experience. And then we have all this data to support that as well. And just because we start you on it, if you don't like it, if you get nervous, like you can come off. There are other ways we can treat your symptoms, but that's just going to be a pill for everyone as opposed to like one thing that covers all of it.
Right.
And everything has risks. There's risks and benefits to every medical treatment out there. So, yeah.
No, that's good. And then when they're on this, you're promoting them to do some strength training.
Yes.
Yeah, I feel like that's big. I feel like, too, it's us in here, Paul, we're a lot of, like, just trying to teach women in a safe manner. That's why we're here. The exercise selection is safe for them. We're making sure their technique is proper. But, like, how much do you really need to load to get these benefits of increasing bone density and increasing muscle mass? And it's usually a bit more than someone may think.
Yeah. So
just a bit.
Just a bit. So I usually will start by saying, like, I try to make it digestible for them.
Yeah.
So if they have never exercised,
Yeah, this is good.
then it's like, okay, we got to start somewhere, and I don't want to overwhelm anybody.
Mm-hmm.
So I refer a lot of people to like Stacy Sims. She's a really
Yeah, her book is
there's
great.
Roar,
Next
and then
Level?
I
Is
forget
that
what the other one is
maybe?
called.
Okay.
Yeah, but she does a lot of like exercise physiology research for women specifically, especially around menopause.
Mm-hmm.
And podcasts, basically stuff that's easy to digest for someone it'll open their mind kind of to the benefits of it. And then, I'm not a personal trainer, but I will refer them to people like you who can actually help them figure out where to start and how to increase safely.
Right.
But it's just like the hardest part, I feel like, is like getting them through the door.
Yeah, you need to be consistent to get these benefits.
Yes.
So it's like, to get an environment, and that's what we try to do, where you're going to enjoy coming in here. Like, that's baseline. I like
Yeah.
to hang out with you guys. I love to hang out with the other people in here. I'm like, okay, if that's enough to get you coming back, that is. And then, while you're in here, we're working on all of these other things. But meeting somebody where they're at.
I was just going to say that. Meeting where they're at. And then also them seeing other people that are around their age. And they're like, holy shit. Look how much weight that person's lifting.
Yeah,
Or
And you go,
what's
they they started where
they
you
started just where you did. And
Right.
also like letting them understand like you don't have to be here 5 days a week. Like you can be here twice a week. If you're here twice a week, every single week,
Right.
that's going to build on those. And then you do other things active outside of here,
Right.
to keep yourself moving and whatnot. But like you don't have to, especially if it's a long drive for you or something like that. Like get up here twice a week. We're going to work hard. We're going to lift some weights. You're going to have some fun. But like at the same time, we have to figure out things you can do outside of here too,
Totally.
to help you just stay out, even if it's just going for a walk.
Yeah.
Like it doesn't have to be overwhelming. It's like both of you said, meet them where they're at.
But I even
the
think
biggest
that's what Stacey Sims says too. Is like a couple. I think it's either 2 or 3. I think of just like an hour of resistance training
2 or
every
3
week.
times a week. Yep.
Yeah, it goes a long way. A long way. Yeah, but it is getting somebody, you meet them where they're at, and then being able to build them up to just like, if you're starting with a 15-pound goblet squat, maybe that's enough. Because for bone density, I think it's like you have to load a bone a tenth of the force it can withstand to be able to increase like osteoblast. So it's like, if the 15 is that for you, that is. And then we're going to build it on up.
Right.
What?
I was just thinking about my one client that like I've been training her. She's 71. I train her online, and she just has like a adjustable kettlebell
Cool.
that goes up to like 40 pounds and whatnot. And like she's always talking about how like heavy everything is. I'm like, well, it's also relative because we only have so much. Like her dumbbells we only had dumbbells up to 10 pounds. I'm like, if I gave you a 12-pound dumbbell and then gave you the 10, you're like, oh, this feels light.
Yeah,
And
exactly.
whatnot. And I'm like, so maybe we need to invest in some, and she still hasn't yet. But we're working. We're
She'll
working
get
on
there.
it. But she is somebody who had a bone density test like pre-COVID, then didn't have one till after because of obviously just like being able to get to the doctor, everything. And like she had improved her bone density even through just the at-home workouts with bands and like light weights. And it's just like it's not too late to start at any point.
Yeah, and
whatnot. And she's also very active outside of it.
Yeah.
Yeah, and we have a lot of new women here who'll come in and we'll ask goals, and they'll say, I have osteopenia. And like, I do not want this to get more, which is cool that just in terms of in the medical system or in their own head, they're seeing as like, oh yeah, I need to strength train. Like, this is a very important
education.
piece.
Yeah. I say that to all my women going through menopause. If you're not already doing this, you need to start doing it. And that's like shocking for a lot of people because it was always like cardio for women was like how you get slim. They never thought about building muscle or building bone. So
That's even changed from like, I started working in this field in 2010. That's even changed a lot since then. It's just like the kind of thought, or majority of women who thought, I don't want to get too bulky. I just need to do cardio. And like not wanting to be too bulky is fair, but it's like, yes, we can structure things appropriately. But that's not going to happen.
Yeah.
And it's going to be harder for you to do so than a male, but still we can control load and volume and help
Like when
you
I
with
was in
that.
the city, I dealt with that because I had clients from 25 to 70 something years old, and with like the younger women, sometimes I would deal with more times than not, like not wanting to get bulky. So like I would trick them into lifting heavier, and then eventually they would be like, "Oh, this is fun. I'm also, I feel better."
Yeah.
And then they'd be like, "I look in the mirror and I feel like I look better," and I'm like, "Yeah. So can we just keep doing this and like not now trust the process. So like sometimes it's like tricking them into trusting the process.
Would you just do the slap some weight in the bar in between sets?
They would be like, how much is it? I'm like, I'm not telling you. I'm not telling you. I have power over you. You've paid me. I am not telling you until we're done. And then I'd be like, I remember this one girl, she was one of my like best clients that was with me for the whole time I was down there. And I was like, yeah, you just did like 315 pounds. It was like hip thrust or something.
Yeah.
And she's like, what? I was like, yeah. So now we're not going to just like kind of go, okay, we're going to lift some weights. And she's like, okay, let's do it.
That's
and
awesome.
She ended up loving it, but like it is just meeting them where they're at and like slowly building them up. And then sometimes you got to trick them, and you know, it's just the way it is.
There's something in here we'll do the like I think you can go up. Like, I don't think so. And then between you'll slap like a 5 on each side and be like,
they won't even know.
Did that feel harder? They're like, no. You're like, that was just 10 more pounds.
or the mental game I'll play with them, especially somebody I know that's like a little bit competitive. When I want them to go up, like let's say it's like bench press, I want them to go up 5 pounds on each side. I'll be like, you can go up, like I'll let you decide, 2.5 or 5 on each side. And they're like, well, 5. Well, 5's on. I'm like, that's what I thought. Yeah. So it's like, again, like understanding who they are, where they're at, where they are mentally, and like how you can kind of push maybe their competitive drive or whatever it is.
Tapping into different parts.
Yeah.
For sure.
And for you too, like that's a big thing in that 90 minutes that you're like, all right, where can I push the right buttons?
Totally.
And whatnot.
Totally.
How'd you get into wanting to work in such a specified kind of realm?
You mean like women's health or like the mama coach thing?
I guess we'll start just women's health and then being like, I want to take this to another level.
Yeah. I honestly don't like. So in college, I was studying medical anthropology. I wasn't sure if I wanted to do med school, public health, nursing. Like I wasn't really sure what path I was going to take. But I remember being in this like women's health seminar.
What's medical anthropology mean?
I'm thinking of his like fossils.
I was going through my head and I was like, I'm going to ask it.
I was like, are you like looking at dead bodies?
It is. I mean, it is anthropology, but through a medical lens. So what health, healing, sickness means to different groups of people, how that's like changed historically.
Like different cultures?
Different cultures, different periods of time. It was pretty interesting.
That is interesting.
Yeah.
Kind of like more like a sociology side of like medicine.
Yeah, kind of.
Yeah.
It was a mixture. I did take a couple sociology classes, a couple anthropology classes, and then like the pre-med stuff. So I made that major myself. They have, UNC has a program where you can just like make up your own major. Oh. And they had a medical anthropology minor that I used as like a baseline, and then I kind of just filled it in. So I was lucky to be able to do that. But because I was always interested in like personal perception of what being healthy means, whether it's spiritually, mentally, physically. And I try to use that approach still today. Like, how are your relationships? What's your social life like? We know loneliness is like a big risk factor for dying early, as equal to smoking X amount of cigarettes. Like, so yeah, that's where that lens kind of came from. But my interest in women's health specifically, I think probably came from more after college. I was working as a medical assistant at an OBGYN clinic in San Francisco, and just seeing how these patients had this like really cool relationship with their provider, and how much how much trust they put in their provider, and how personal of a subject it is, family building. You know, it's a very intimate group of organs that you're working with and stuff like that. And I just kind of fell in love with it. So yeah, that's how I decided to specialize in women's health when I went to nursing school. And then I found out about the mama coach through a friend, actually, who had started her own practice.
Which that's like a organization that you then work under, and they help you create structure.
Yeah. So it was founded by a nurse up in Canada, probably I think about 10 years ago. She had gotten burnout doing her bedside nursing and decided to start her own business. And the mama coach started out for nurses who wanted to go support new moms. So it was doing stuff with their infants. So it was starting solids, sleeping, all this kind of stuff, and then just supporting the moms and the dads through that. And then she got so much success from that, decided to expand into more like women's health areas. So menopause, now fertility. They do, they offer services in family health. So if you are a nurse and you want to start your own practice, you can open it with the mama coach, and they offer all this support, legal stuff, just kind of the basic steps of how to open a practice. And then they do a lot of professional development. So they'll have doctors and nutritionists come and give talks for us. It's a way to network and kind of help each other with, if you're struggling with marketing or whatever. So there's a lot of resources that you get from being a part of that.
That's pretty cool.
It is cool. Yeah.
And it's been helpful for you, you feel like?
It has.
That's
yeah.
awesome.
I don't think I would have ever started my own, I don't know anything about business. So
Right.
I wouldn't have felt empowered to do that if I hadn't had the support.
And there are,
from
I'm
them.
sure, legalities in terms of practicing as an NP on your own. And I'm sure every state's different,
Yes,
too.
every state's different. In New York, if you have a certain amount of hours that you've practiced, you don't need to have physician supervision.
Right.
So, yeah, I'm lucky.
Well, you got to that point, so that helps you be able to do what you want to do and
Exactly.
build the business you're building.
On the anthropology, if people were to look back at us today as a society and how we live, yeah, you look back and go like, oh man, all the like what do you see? What are glaring things you see? Obviously, we talked about processed foods, we talk about inactivity, but what are
screens? I'm sure.
Yeah.
We were talking about the record player before we started. Like, I just read an article, I think it was Wall Street Journal, about how more and more people are like getting analog rooms in their houses where there's like no like screen, like touch screen. It's all like dials, and like we miss like the texture of like touching a dial.
Yeah, the phone on the wall where we had one of those.
The rotary?
The circle. You had to put your finger in the thing and you had to turn it with the cord.
But just getting like so like obsessed with social media and that makes you even more sedentary, and then you're not talking to the people around you. We just talk about loneliness. Like, I think, the processed foods and the screens are like two big things.
Yeah, there's a book called, I don't know if I've mentioned it here before, probably, called Why Zebras Don't Get Ulcers by this guy Robert Zapolsky. He's
yeah.
do you know
Did he do Behave?
He's somewhere out in California.
Okay.
Paul, look him up where he teaches and what his profession is. But it's a really
How
cool
do you
look
spell
at
his last name?
Zapolsky AP. Just search Why Zebras Don't Get
tricky one.
Ulcers. But yeah, look up what his like background is and what he teaches or where in California. But it's really just like a look at our body and our endocrine system, and like our body is still a caveman body, but we are living in this modern world, and that our normal stress response is meant to be like, I have to go hunt this food, or something's trying to get me. I have to protect myself, get my food, and now I can just chill out, eat, and rest. Where today, instead of just having that fight and flight kind of autonomic response during these moments where I'm like hunting or being hunted, now I'm having it when I'm driving, when I'm scrolling social media, when I'm interacting with colleagues, and you just have this.
I know.
This all day.
Did you say Behave, the biology of humans at our best and worst?
Is that
him as well?
Yes.
Okay.
So same guy.
That was the one you were saying?
Yeah.
Yes, that's the same
He's
guy.
a cool guy.
But you've read that then?
I think I started it. That's a big one. I don't know if I finished it.
Yep.
I'll have to read the zebras one.
Yeah, but probably same concepts.
He's
What's
got some interesting titles. Monkey Love
That's one of his books.
and Other Essays on Our Lives as Animals.
Yeah, but it's just a cool perspective. And it makes sense from just like a sympathetic, parasympathetic standpoint.
Absolutely.
And kind of that hormonal cascade on our body.
Yeah. And people just having the awareness, I think, is like a big part of addressing it, because you're so enmeshed in it. We're so used to it. We don't even think twice if we get a text and then get stressed out about it and feel like we have to answer right away. But it's just like, I recommend to a lot of people like meditation, yoga, breathing exercises, like just kind of helping yourself ground throughout the day a couple times, I think can make a big difference.
Well, I was even like with athletes in here, I was talking with them about like breathing exercises, and I'm like, watch any professional athlete before a game.
Yeah.
Like the amount of times I've seen like LeBron James or Patrick Mahomes or Tom Brady or any of the best, even like the guys that aren't the best athletes, just best ones they're doing intentional breathing to get their mindset right and whatnot, and like that helps a lot. And I think just being mindful of that kind of stuff, and like I'll take like on Sunday sometimes I'll literally just try to leave my phone like upstairs.
Yeah.
I'll have my watch on so that way if I see a text that's important that I need to answer, I'll be like, all right, let me go upstairs. Plus that makes me get more steps in too.
There you go.
Yeah.
Yeah, but that's hard. It's easier said than done, but
Absolutely.
it's true.
Yeah.
Yeah, social media is a big one too, though.
I know. I like a big part of what the Mama Coach, people recommend for marketing is on social media, and that's been so hard for me because I've never been like a big social media person, and like just getting on there and like spending time on Canva to make like a stupid. I'm like,
I know.
I think I want to do this. I'm just gonna find other ways to,
I know
to get my name out there. I really don't.
Yeah,
enjoy
it's
it.
I wouldn't be on social media if I didn't own this business.
Yeah.
There's no way. I've created a boundary with my personal life where I post nothing
Actually,
personal.
now that we have that new business suite, I might deactivate my personal Instagram
There you
for a
go.
while. Because like that's the only reason I haven't like deleted the Instagram
wow,
on my
Paul.
phone was because I'm like I need it for my.
Do you think you'll do that?
I think
I'd be proud of you if you did. I wish
like,
I could.
I don't post anything.
Yeah.
I literally don't post anything.
Yeah, because whatever, we're learning still. But yeah, on the access you have now, Paul, you can't scroll on the feed. You just can function as like a behind the scenes on our Instagram.
So I might do a little break.
Wow.
Do a little
Instagram
detox.
break.
Yeah.
Because I've wanted to for a long time and I just haven't.
That's a good idea, Paul.
So it might happen.
You should do
You
it.
might have just inspired that.
Good.
Yeah. What's been the hardest? It's just been stuff on the business front. Like when you have a patient, you do your thing.
Yeah. Just getting my name out there. I didn't realize how much work it was going to be to build a practice. I think. Yeah.
Yeah. And you don't have a physical location for Mama Coach, true?
Correct. For right now, it's all virtual. If someone wants to do in person and they live reasonably close, I can do like house visits. But usually it's just over like video call.
Yeah, but which is a good start because you don't want to have to worry about the overhead of like
Right.
paying for somewhere.
And
Exactly.
especially if you're still obviously working, your other job.
Yeah,
It makes it a little more flexible
totally.
for you to not have to like drive all over the place or have to be in a location. Like it's like, okay, I can just, if I'm in my car, I can hop on a video call.
Yeah.
So
Absolutely.
Are you ever with the client at your full time now and you go, oh, I could help you so much more if?
Yeah.
Are you allowed to?
No.
Yeah, that's the hard part.
Conflict of interest.
Yeah, correct.
Yeah.
That's what I figured.
It's a bummer.
Yeah, but you must feel like that.
It's hard. Yeah.
Like, I could do so much more.
Yeah. And I do try to incorporate that. Like everything I'm doing with the Mama Coach, I try to bring it in.
Yeah, it must make you a much better like practitioner in that sense.
I think it does. But it's hard if, like I said, if the Mama Coach patients kind of self-select, and that's usually not the case elsewhere.
Right.
well,
But-
and I'm sure with the Mama Coach thing too, it probably allows you for the ones that are going to like your regular practice that to advocate for themselves with
Yeah.
other doctors and stuff like that. So now you can tell them like, hey, like just make sure you're asking like this, and this.
Right.
Like I may not be able to help you with the way I want to, but I can give you the questions to ask so that way you can get the answers you're supposed to get.
Yeah,
And if that
absolutely.
leads you down the road to me, then great. If
Yeah.
not, then and you get the answers you want, even better.
Even better, yeah.
Is hormone replacement covered by insurance?
Usually, yeah.
Okay.
Yeah.
Is most of the, because if people are seeing you from Mama Coach, that's an out-of-pocket fee.
Yes.
But blood work, medication, hormone, that all?
Usually, yeah. If it's not covered, usually they can even submit for reimbursement after the fact. And just so people know, I take HSA and FSA payments too.
Mm-hmm.
Yeah.
Because Mama Coach, you said it was originated in Canada?
The nurse who started it is Canadian, and now there are people in the UK, New Zealand, Australia,
Yep.
like nurses from all over
wild.
the world. Yeah.
Which is because a lot of those places are probably universal health care, so they don't have to, correct?
Yeah.
Would you be in favor of that here or no? I'm always curious what medical people think when they're on.
It's so complicated.
I know, I feel the same way.
Because, like, you'll hear, the benefits of it are, it's free. But then the downside that I often hear is the wait times are insane. To get into a specialist is like a year plus. So it's like, well, then is it even worth it being free if you have to wait that long?
Right.
Yeah.
Right. There's probably some healthy, I don't know. We're like, if you want to pay for somebody out of pocket, go for it.
Yeah.
But at least, because it would probably help people who aren't getting into doctors, say with a PCOS or an endo early on, just because they don't have health care, to be able to maybe get ahead of things if they
Right.
have access.
At least start the process.
Yeah. Yeah. So like that's a plus.
Yeah.
But yeah, it's a tricky one. That seems to be the story, or that most of the NPs we've had on think is like, well, in theory it's good, but when you put it into application,
Yeah.
it can be tricky.
It's very tricky.
And then getting there is also tricky.
Oh yeah, like I don't think we're structured to ever get there with insurance companies. It's a great point.
Yeah.
Has this new Trump and RFK changing so many things, has that impacted how you're treating day to day, or is that probably more of a primary care physician in terms of changing vaccine schedules and
Right. Yeah, honestly, for me specifically, it hasn't made much of an impact. Working at like a rural hospital, how like the Medicaid and Medicare changes and the lower reimbursements, like we're all a little bit nervous about how that's going to like downstream affect how much money the hospital is getting, and then if we're going to be able to stay open. But like for my, private practice and my even just day to day at my normal job,
Doesn't
I haven't
impact.
noticed a ton. Yeah.
Yep.
At least for now.
For
We'll see.
now? Yeah, right. Yeah, who knows what's to come next week?
Yeah.
Yeah, good point. No, this was great. I appreciate you
Thank you
coming
guys
on.
so much. This was so fun.
Your first pod, you did awesome.
Yeah, thank you.
You crushed that. You only looked at your notes once.
Just once.
Yeah.
Yeah, because Mike had to get all scientific on you and be like, "Hey, what are the other
No, it's
estrogens?"
good.
here?"
No, I thought this
I'm
was
just kidding. I'm
good
just kidding.
because
It was good.
yeah, a lot of the time. I mean, this is hopefully you felt like this was laid back and we were
Yeah.
just like having a chill conversation. But I
Absolutely.
wanted to make sure that like this was going to be informative.
Yeah.
Because like I just think about women in here who just they're struggling going to perimenopause and they don't understand what's going on with their body and they kind of feel hopeless
Yeah.
and they're taking these extreme actions with calorie restriction or exercise. And yeah, I think this would be nice just to be able to listen to and go, okay, like this is why I'm feeling how I'm feeling.
Yeah.
This is a real thing.
You're
this
not
isn't,
alone.
This
You're not
isn't in
going
my
crazy.
head.
Yes, definitely.
And maybe give, now they have someone they can go to.
Yeah.
Yes.
They may want to go, all right, I'm ready to take that leap because now they've been educated
Right.
through listening to you and what we've provided with them today. So hopefully this helps them and then also helps us.
Helps us a ton.
helps
This was
us
kind of a
because-
selfish one too, because Paul, we get asked this a lot, and I go, "Well, I know this all matters and it's real."
And I also have two sisters that are in their 40s. So
Yeah.
it's
Yeah.
like, it's one of those things. It's like, hey, if I can help them
Right.
with some of this stuff too, it's like I want to
It's good for
do
everyone to know.
my best to do that. So
Absolutely.
Yeah,
Well, I'm
hun-
so happy to be on. Thank
Thanks,
you.
Lisa. This was great. Just plug anything you want before we hop off.
Yeah, so you can just Google me, Lisa Morris, the Mama Coach. You can book a free discovery call if you're like unsure if you're a good fit, unsure what our approach would look like, if you have questions about getting pregnant, if you're going through IVF and need some additional support there, or if you're going through perimenopause, just reach out and, we can decide if it's a good fit. But
Perfect.
Yeah.
Awesome.
One more. How do you know when you're going to send somebody for IVF? Is it just an urgency thing, like, or a woman's a little bit older where you're like, I'm going to send you now versus I'm going to try some other things?
yeah, so it really depends, on their age, their timeline, and what's going on specifically. If it looks like we're really concerned about like low ovarian reserve and they're, if they're in their late 30s, their blood work isn't looking great. We did like an antral follicle count on an ultrasound and they had very few follicles. I'll probably refer a lot quicker. But if they are a bit younger or have, PCOS, something very clear cut going on that they want to try to address more naturally first, then yeah, that's something that we can work on together before we make the next step to refer out.
Cool.
Yeah.
Perfect. Sweet. Thanks, Lisa.
Thank
This
you.
was great, and we'll catch everybody next time. Thank you.